Now, as I said, this session is being organized with my colleagues, Tanya Gunter and Nicole. Thank you very much for being with us and for organizing this. Next slide, please. Next. We have to say that monitoring and evaluation is part of our daily life. When we do monitoring, we just need to define really what we are trying to measure. How can we measure them? We define how to analyze data, and then we can't say we are good, we are not good. So how can we, adjust our programs if needed? This is an example of how do we make sure that your water source is not contaminated, for example, by the latrine. So you say, I set 10 meters between my latrine and the water source, and if the system measures that, I'm good. So we're doing quite well in doing this in our own program. What we are not doing so good sometimes is to share it. Next slide, please. Across different programs, across different projects, and then across countries. So sometimes we are measuring the same things, but we are not speaking the same language. Sometimes in the best case scenario, just only the language. Sometimes we are not even measuring the same thing. So this evening we will, invite you to have a launch of the CCM indicators, because this is the first attempt to design, some common language around the indicators on CCM for us to share the same indicators and the same measurement units. This session will be this evening. There's an evening lunch. But in the best case scenario, we are measuring the same thing, but we are not telling it in the same way. Sometimes in the worst case scenario, we are not measuring the same thing. And in the worst case scenario also, we are not sharing our information. Next slide, please. And then we could code. Even if we have the same indicators, we are measuring them sometimes, then we are destroying each other because we are not sharing whatever we are doing. So this is the first attempt to share examples, to share what we are doing. Next slide, please. Now we need to gather information, but we also need to use them. We need to translate them into knowledge. And for that, next slide please. In this session, we will share experiences. We will discuss the development and integration of monitoring system in other systems. We will share experience on how we use this information and these indicators, and we will have some discussion on innovation. We have learned some lessons through this implementation of our CCM program. My colleague Laura Miller from Sierra Leone, she is the health coordinator of International Rescue Committee in Sierra Leone. She is working on CCM program in Sierra Leone since 2011. Laura, please.
So this morning I'm presenting on behalf of Sierra Leone, and I'm going to talk about iCCM treatment data. As I said in the beginning, iCCM started in Sierra Leone as really an NGO-led initiative. At the district level, we were working with the district health management teams, but kind of the direction of the program was led primarily by NGOs. Okay. And then in 2009, about 9 months ago, there was a reorganization in the national leadership within the Ministry of Health of Sierra Leone, and the Director of Primary Health Care launched a Community Health Program Technical Working Group. So that has really changed the direction of community health and iCCM in Sierra Leone, because the ministry has taken kind of national leadership on the program, and there's a lot more coordination and harmonization of activities. And the leadership is there at the national level, and it has trickled down to the district and the health facility level. Okay, so this is a graph showing the proportion of treatments given between community health workers and at the health facility in Kono district. The gray is showing the proportion of treatments from the health facility, and the yellow is from the community health workers. So this is for malaria, pneumonia, and diarrhea. So CHWs were well supported with medicines and were supervised well. They were giving about 50% of the treatments between the health facility and the community health workers for children under 5. For malaria, it was a bit higher. They were providing about 60% of the treatments. The community health workers were providing about 60% of the treatments. For pneumonia and diarrhea, it was a little bit lower. So in this data is coming from the IRC monitoring system. And so just to also give some numbers to these proportions, the community health workers were giving, in Kono, they were giving about 7,000 iCCM treatments a month to children under 5. So in Kono, there were about 850 community health workers, serving a population of about 50,000 children under 5, giving about 7,000 treatments per month. Okay, so where does all of that data go? There's a lot of data being generated every month by a large number of community health workers. So this is the community health worker patient register that was being used at the time when the data that I just showed was being collected. It's just treatment. There's information about treatments given, and it's disaggregated by time and age. And then there's also information about stockouts, reporting CHWs, and now there's actually some information about maternal and newborn health visits that are conducted. So this form was introduced in 2011. So this slide is showing what has happened since the introduction of Form 6. So prior to June 2011, there was not a mechanism for all of these community treatments that were happening to be recorded through HMIS. So the green represents the treatments that are reported by the ministry. The yellow are the treatments that were reported through the IRC's parallel kind of system of reporting. So as you can see, as the form was introduced, there's been a gradual increase in the proportion in the ability for Form 6 to capture all of the CHW malaria treatments. So this is just malaria, not the 3 diseases. CHWs who have low literacy skills or no literacy skills. They stick up the job aids in their house and have strings underneath, say, a picture of a child with fever, and they'll tie a knot for every child they see who has fever, so that then when the person comes back to the village who knows how to write, they will make sure that person writes all of the information that they, for all of the kind of children that they saw and treatments provided. So as much as possible, we've tried to make it so that literacy does not exclude, no literacy does not exclude people from becoming CHWs. So one peer supervisor oversees 8 to 16 CHWs, and they use this peer supervisor compiled monthly report to add to, there's a line listing for each CHW, and they summarize, number of treatments, number of malaria treatments, number of diarrhea treatments. And then the peer supervisor is able to then add those totals and have a total for the health facility. So the story here is that there's been a huge improvement. And I think that there's been a huge improvement since the introduction of Form 6 for the ministry to be able to capture all of the community treatment data. But there's still a ways to go for it to be complete. Okay, so monitoring data is one of the main sources of data that gets to decision makers about health programs. But there's another source, which is survey data. So this is a picture of a survey that was conducted in January 2013. It was conducted by the CDC, and it was to evaluate the impact of iCCM in Kono. So at the same time, the malaria indicator survey was being conducted. So we were quite excited that the surveys were being done at the same time, and thought it would be an interesting way to kind of compare and validate some of our results. So the question I was trying to answer, is correct data getting to decision makers? So I would say yes, there has been a major improvement in HMIS to capture CHW treatment data. We as IRC can report very high treatment numbers
one of the highest child mortality rates, and this is because the country has been through a lot over the last 2 decades. Civil war has pretty much ravaged the country, and in a very, very large country, up to 2010, they only had under 100 kilometers of paved roads. And at the same time, there's about 1,200 health facilities, but majority of them either are not functional or they simply don't have stock. So it's a very, very tough environment for the people who live there. Global Fund and DFID fund a very large iCCM program in South Sudan. iCCM is actually critical for countries like South Sudan, given that there's very limited access to health facilities. So people usually have to walk long distances, so 50 kilometers or more, to get to the nearest health facility. And even if you get there, you're not guaranteed to get treated because of stockouts. At the moment, there's roughly 8,000 community health workers working in 9 out of 10 of the states in South Sudan. So it's actually a very big program. And the program focuses on malaria, pneumonia, and diarrhea. And as of this year, they're expanding to nutrition as well. Next slide. Right, so in terms of the monitoring framework for the program, the core information needs for the program are around caseload data. So basically, how many people are coming forward demonstrating the symptoms that we're looking for, and what's the eventual treatment that they're getting. Stock availability data, so checking to see whether CHWs are properly stocked, and issues around quality of care. And the quality of care is mainly through patient follow-up by the supervisors of the CHWs. And the data collection tools that they use are basically similar to what's used in other countries. So you've got the patient register that's used by the CHW, and then both the supervisor and the field officers also have checklists that they go through when they go in to undertake visits. The data for iCCM is currently managed electronically using DHIS 1.4, which is sort of the dragon version of DHIS. DHIS 2 is what's being used elsewhere, and I think there's a presentation on that later. This version of DHIS is more suited for difficult settings where you don't have good internet capabilities. And then there's almost 9,000 people involved in data collection activity. So if you look at the circles on the right-hand side, so you've got 8,000 CHWs, approximately 600 supervisors, working out of working for 60 field officers in 15 field offices across 6 NGOs. So basically, the scale and operation in terms of collecting information that's actually supposed to be harmonized is pretty large. Next slide, please. Right, so I thought I'll focus on 5 key lessons learned, and this is very high level, and most of it is you would say is a no-brainer, but you know, we learn through mistakes in South Sudan, so I think it's important to highlight some of these lessons. Alright, so the first lesson is to do with keeping the data needs simple. With the many countries that I work with, this is a classic mistake that NGOs tend to do. And also within the field offices, you may have people who have high school education, but in terms of their numeracy and IT skills, it's also a struggle. So you really have to take into account these things before you try and set up a system. So with regards to CHWs, the design of the tools needs to take into account literacy levels. So that's an example of the tool that's being used in South Sudan currently. And some of the changes that we made to the tool were to make it more visual. So up to about 2010, the tools that they were using in South Sudan had no pictures. So considering you're using a CHW who is illiterate, and you give him a tool with absolutely no pictures, and sort of you teach them where to put stuff, you know, it was a dying system. Another thing that we needed to make sure was the size of the registers. So we found out that when we're dealing with illiterate CBDs, they're called CBDs, it's the same as CHWs. The issue is not only about writing, the issue is also about putting information in a straight line. So this is something that we learned through mistakes, because we had A4 size registers and they really struggled to put all the information on the same line. So we had to actually expand and use A3 registers, which gives them a lot more room to put down the information. And doing something as simple as that really improved the quality of the information that we were collecting. And then another thing is to do with the supervision ratio. So how many CHWs are supervised by each of the supervisors? So in a low capacity setting, you want to make sure that you get that number right. So in South Sudan at the moment, it's usually between 10 to 15 CHWs per supervisor. So the next thing to consider is how your program is going to link to national systems. So we had 6 international NGOs, all with their styles of working, all with their own capacities, developing systems to suit them. So one of the things that we had to do was to integrate the approach to which they use to collect information, to make sure that it's harmonized across departments, and also it's in line with what government requires going forward, given that from a sustainability perspective, governments are likely to take over. And we had to do exactly the same thing by introducing the HIS, which is also what's being used by government. Next slide. Limiting movement of paper files. If you're in a difficult setting, it is very difficult to move information from point A to point B. So one of the things that you need to do is to try and consider how you can make technology work for you. Because you find like somewhere like South Sudan, the road network is much worse than internet connectivity. So sometimes you're better off investing in IT right down to the lowest level, so that you can manage to get the information out. We will field offices that take that even for a couple of months they become inaccessible. So getting information out of them is really, really difficult. And you also have to ensure that there's power and connectivity to make this work. So the top picture is an example of us going on a field visit to do data quality assurance. That's actually the top of the 4x4 that we're using, because we had to cross a river to get to the other side. And once that river is flooded, you can't access the area for months. Next slide. Last thing is make sure that how you set up the system, if people are low capacity, visuals are very good in trying to get the message across. And even in the style of indicators that you use, it's better to simplify. So for example, if you're talking about stock, instead of presenting stock information as the stock balance, you can try and transform that information into the number of months of stock that you have left. So a small adjustment like that makes people at the warehouse very responsive. So if you traffic light it and they know that they've only got 2 more months of stock left, they react to that much more than